Hi, I'm Derek, and I want to take the time to discuss wound care within long-term care facilities. Can you tell me what your name and title is, please?
Celeste Jenkins, and I'm a LPN unit manager.
And what has your experience been within long-term care?
I've worked as a nurse in long-term care for 13 years and a CNA prior to that.
So I'm sure you've heard many misconceptions with long-term care. What do you believe is the biggest misconception regarding wound care and pressure areas?
I think the biggest misconception made when someone has a pressure area or a wound developed is neglect. Especially if someone's coming from the nursing home, people think that they've been neglected.
So with neglect, how do you as a unit manager ensure that that does not happen?
All of our residents have pressure relieving mattresses. They also have pressure reducing cushions in their wheelchairs where they spend most of their time. Also, we can apply cushions in their recliners. And then if a wound does develop or a resident is admitted with a wound and we know that upon admission, we can apply different pressure relieving devices like an air mattress to the bed.
So are all those part of a protocol then?
Yes.
You have it set for all patients who come in?
Yes.
So what is the biggest reason why a pressure wound develops?
A lot of times a pressure wound develops if the resident is non-compliant with turning and repositioning. We attempt to turn the resident every 2 hours, sometimes every hour, off of pressure areas in their body. A lot of residents do not wish to be turned, and they have that right not to be turned if they don't want to. A lot of residents are comfortable in one position, but that does cause a lot of pressure, especially on their bottom.
Whenever you're admitting patients, do you see that many patients who come from home have pressure areas? Is that the majority?
We see a few. A lot of times we see residents come from home that haven't been able to be in good nutritional status for a while, not being able to fix their meals and eat 100% of meals like they used to. A lot of times spouses have been dependent on each other. The other spouse may not be up to par to taking care of that resident like they used to be able to. So we do see some pressure areas come from home.
So what are some common treatments that you have used to treat these wounds that you're seeing?
A lot of times we can use certain creams to apply to the wound, or we use a foam dressing. Most of it is changed daily. Some wound care you can change every 3 days. Some you can even go to a week. It just depends how the wound is healing. But we would contact the physician and suggest treatments for the wound.
So the physician is receptive to what the nurse usually recommends? Is that kind of...
Most of the time, yes, because the nurse has seen the wound. And until the doctor can come in our facility and see the wound himself, they usually take a suggestive treatment from the nurse.
So if you've exhausted all options on treatments within the facility, what would be the next step for a patient?
We do have a wound clinic here in town. A few of our residents have gone out. They make weekly visits to the wound clinic, and that physician at the wound clinic usually changes treatment weekly, and then the nursing home will follow out those treatments as ordered.
So what type of wounds would you send?
Usually we send people to the wound clinic that have wounds that we haven't been able to heal here. A lot of times leg wounds, foot wounds, wounds that needed debridement. We can also take care of wound vac wounds here, but a lot of times residents that do come with wound vacs, they have been seeing the wound clinic prior to admission, so we just continue that.
So, can you tell me about a time that you've had a patient who received treatment from the wound clinic and was successful with healing?
Actually, I did have a resident that came not from the wound clinic, but from a specialty hospital for wounds. The resident was admitted to us with stage 4 and stage 5 wounds on each of the trochanters. With about 2 or 3 times of changing the treatment, we were able to heal the wound in about 6 to 7 months. It was a long time. The resident didn't have very good nutritional status and was a peg feeding and also eating meals by mouth. It just took a lot of rehabilitation for the strength, turning, repositioning, special mattresses.
So all those protocols that you had discussed earlier, you were using that along with the different
wounds,
treatments.
Have been healed now for probably another 6 months with preventative treatment.
And after a wound's healed, what do you do to prevent it from happening? Do you continue with any preventative treatments? Or?
We usually like to, after the wound is healed, continue with maybe a preventative dressing for a while. And after the preventative dressing has continued to not let the wound reopen, we can just do a cream, usually a protective cream, just as a barrier cream to the skin.
Well, that's really wonderful. I want to thank you for your time and updating me on wound care and teaching us in the class more about how to treat these.
You're welcome.
Thank you.